Okay, welcome everybody. Thanks for being here today. I don't know if anyone has any quick announcements before we get started. Anything going on in your world that you'd like to bring up? I gotta mute my computer. Okay, well, can everyone hear me? Somebody, thumbs up, fantastic, thank you. All right. Thanks for being here today. We have Kirsten from the Community Nurse Project, and I thought I would turn it over to her. Thank you so much for being here today. Sorry I got started a little bit late. We actually took some great testimony in the Human Services Committee earlier today looking at nursing homes and how we're funding emergency financial relief and some really good data that came out on nursing homes. So that was our committee discussion just now. We just left. So I'm sure there'll be more talk around workforce and how people can move from skilled nursing to home and community-based providers and back and forth, and what that looks like in the future. So definitely workforce is one of the big drivers, and actually community nurse would be super helpful in making sure people we can be proactive in people's healthcare and not end up needing that skilled nursing care. So our most expensive level of care. So I'll turn it over. Thank you so much for being here today.
Yeah, thank you, Dan. And thank you so much for caring about older Vermonters. It's really, we had a brief conversation yesterday about something different, and it's just really inspirational how much you care. So thank you for that. Can I share my screen? I'm
Yes.
gonna try.
Yeah, you should be allowed to. If not, push the buttons in the right order. There it goes. Okay, it looks like it's working.
All right. And just so everybody knows, that is a picture of the Great Dismal Swamp, which is a beautiful place actually between Virginia and North Carolina that we recently visited on our boat. So
Cool.
that's my screensaver. So let's see if I can get the slides. There we go. So I'm going to put the slides up, and when I do this, I can't really see you all so well. So if you have a question, please just come off mute and ask. I really hope that we can have this more conversational. Okay. I am the executive director for Community Nurse Connection. There's some contact information here, and there'll be contact information at the end. So I thought I would share a little bit about the history of nursing in the home, and I'm trying to move the squares around so I can see my slides. Sorry about that. So basically, before the mid 1800s, there was care at home for, quote, the sick poor, and that was mostly by neighbors or religious orders or lay people. Around the mid 1800s, there was this movement for district nursing. So, inspired by Florence Nightingale, some folks in England started talking about nurses doing home visits, again, still mostly for the poor. But there was a lot of talk, and they coined the term health nurses and emphasized that nurses should teach healthy living. Kind of sounds familiar to what we're talking about today. And then came along public health nursing. So Lillian Wald, one of my nursing heroes, I love to read about her. She really brought the idea of the public health nursing, mostly on the streets of New York City. But she really argued that addressing social and economic conditions will improve health. Again, some of the things we're all talking about today. So, oops, sorry about that. Clicked too fast. So these visiting nurse associations or visiting angels and all of this, nurses started doing home visits. There really wasn't any regulatory or payment structure. They really just started this neighborhood nursing. And then in about 1965, Medicare got involved. And this is my opinion, they really disrupted community nursing by shifting the community nursing from holistic, preventative, education, really focusing on those social risk factors in preventative care to short-term acute post-hospitalization nursing care. Not a bad thing. We need that. But unfortunately, around the early 70s, these community nurse organizations started to dissolve because of the reimbursement policies and the fragmented medicalized services that community nursing home health agencies, the VNAs, had to provide. They really, Medicare focused reimbursement and very strict documentation on skilled care and homebound folks, which really a lot of older Vermonters living at the end of the dead end road, even though they don't have a car, they didn't meet the homebound rule or they didn't need quote skilled care, but they still could benefit from a wellness check from a highly skilled registered nurse. So again, a lot of restructuring happened in the 70s and 80s, basically because of this medicalized, fragmented Medicare rules and regulations. So in about 2012, there were two clinicians in the Upper Valley, and Upper Valley really kind of well, it's broadly defined, but it includes Vermont and New Hampshire, kind of in the middle part of the states, but it does go across the river on both sides. But two clinicians, Dr. Dennis McCullough, who was a geriatrician, and his friend Lori Harding, who's an RN, they really recognized that this Medicare, Medicaid, fragmented, medicalized service created a gap for many older adults struggling with chronic illnesses, transitions of care, and aging challenges. Their solution was to kind of go back to the early 1900s and convene community-based grassroots efforts to embed registered nurses into communities driven by care, not reimbursement. So a little bit about our organization, Community Nurse Connection. We are a very small nonprofit. We are a 501(c)(3). We're a convening organization. So our goal is to organize and bring people together around ideas and resources to improve the quality of life for older adults. We help by creating roadmaps for the development of community nurse projects. We do offer a confidential electronic documentation system, and I'll show you some of the data in a few slides. And we do get these community nursing projects reports in monthly, quarterly, and annual formats. We host a virtual, we used to call it a nursing peer support meeting. We've transitioned and now we call it a nurse learning collaborative because we really all learn from each other. And we do offer some grants for some communities to start nursing programs. A little bit about how it works. Nurses are employed by towns, cities, communities, faith-based organizations. There's new models coming up all the time. These programs are independent of the mainstream healthcare and reimbursement systems. And what I really mean by that is they are not governed by the Medicare, Medicaid, private insurance rules. So they don't bill for services, and therefore they are not restricted by the coding and the regulation of those payer sources. Referrals go directly to the communities. They do not go through Community Nurse Connection. So they go directly to the communities from primary care providers, hospitals, area agencies on aging, friends, neighbors, and clergy. I will say about 50% of the referrals come from the community. So either a neighbor, a self-referral, or a friend. And as I said before, there's no charge to the client. Let's see. Okay, so a little bit about the data that we collected, and these are Vermont numbers for the nurses that are using the system. The nurses, again, they don't report to our organization. They don't pay membership dues. We really just support them the best we can. So they're not obligated to use the system, but for the nurse programs that are using the system in the year 2025, and I'm really impressed by some of these numbers, they served 488 clients. So that means those clients had at least one encounter in the year 2025. The median age of these clients is 79. So these are older Vermonters. So, really we think about the 75 plus folks who are falling through the cracks. New clients in 2025 in the state of Vermont were 296 clients. And that is defined by somebody, an older adult that had an encounter this year and didn't have an encounter the previous year. So we can put clients on a unactive list for a while until they need services again. We really never discharge. We only discharge if they move out of the territory served or the patient dies. Other than that, we keep them kind of on our list, maybe not our active list, but on our list to pay attention to. I mean, really impressive. Again, this is Vermont numbers only. There were 4,410 encounters. And the pie chart below talks about how we gather information on encounters. So we have a home visit, meaning the nurse actually goes to the home. We also have an in-person visit, and that means the nurse may meet somebody, but not in the home. So it may be the library, it could be the town hall, it could be the nurse goes to a physician visit with them, or but it's not allowed to get, or the for whatever reason does not get into the home. Sometimes it takes meeting them at Dunkin' Donuts or the library a few times to build that trust before that nurse can get into the home. Okay. So again, this is a really impressive slide, and I apologize because our interventions are so the words are so long, I can't really get it on the slide and show you the numbers. So I'll go through a little bit. And again, these are Vermont outcomes for the year 2025 for the community served, and I'll show you the community served in a few minutes. So prevented emergency department visits. 213 times a nurse prevented an urgent care or an ED visit. Reduced anxiety for the client or the caregiver, 2,737 times. Reduced isolation, 1,803 times. Reduced a fall risk, 659 times. Improved understanding of medication, 723 times, and able to remain safely at home, 1,571 times. These numbers are very, very impressive, and we're not serving a lot of communities in Vermont. So a little bit about the models, and we're learning every day that however a community defines their community and however they want to hold up a model with a community nurse, a highly skilled RN, we're figuring out new ways. So some of the examples, the nurse is an employee or contracted with an aging in place or nonprofit. So an example of this is Heartland, Vermont, where the nurses are actually employees of Aging in Heartland, which is a separate 501(c)(3). The nurse is an employee of the municipality and reports to the emergency management. An example of this is Hartford, Vermont. The nurse is actually an employee of the municipality and reports directly to the fire chief. It's a really interesting model. We also have a model, it's not listed here, where in Tunbridge, the nurse is a town employee and she's also the town health officer. Another really interesting model that I think we could explore more of in Vermont. Um, Another example is the nurse is an employee of the municipality and reports to Parks and Recreation. This is a model that is happening in Hanover, New Hampshire, and really allows the nurse to get more involved in educational planning under the Parks and Recreational budget. So more Tai Chi offering and whatnot in the town of Hanover. Um, the nurse may also be contracted by a nonprofit who's acting as a fiscal sponsor while the group is seeking nonprofit status. So, this is a way a lot of organizations start a community nursing program. An example of this is Windsor, Vermont. The Upper Valley Public Health Council is acting as a fiscal sponsor. And so that when they're raising money, this fiscal sponsor is holding it until they can form a nonprofit status. Another current example is the nurse is an employee or contracted with a parish, a church, or a religious organization. And an example of this is Lyme, New Hampshire. And actually, that was the Sharon, Vermont model for a while. Again, we're exploring new models all of the time. There's a model in Chelsea, Vermont that is really unique where the nurse is an employee of First Branch Ambulance. So the actual ambulance service, which is a separate 501(c)(3), and the town of Chelsea, Vermont contracts with First Branch Ambulance for hours for the community nurse. So again, there's a lot of different ways that this model can be rolled out in very, very rural areas. I always think it's important to talk about the finances because usually that's the first question I get if I don't put the slide up here. So really, this community nursing is an affordable way to help keep residents safe at home. It's not the only solution. It's part of a lot of robust services that Vermont is offering. Most communities start at about 10 hours per week. It's really important to pay competitive wages so that you get those highly skilled nurses. We've seen registered nurses. We've seen a couple of communities do it as volunteers. I actually was just on the phone with a former community nurse from Wilmington, Vermont. She was volunteer most of the time, didn't really collect data. And when she retired, the town did not re-implement community nursing into their town. So we really have learned over the years that a competitive rate compared to the hospitals, the nursing home in that area is really important for the sustainability of a program. So basically, the cost for a community, usually for a town municipality area, is about $30,000 a year. It's not a lot of money, especially if you start looking at town budgets and how much they're paying for health and well-being. Really to put this into that health and well-being is not a big lift. We can't prove it yet, but we're hoping to find some students to help us with a research project. But we really believe for a town, this is budget neutral. And the reason is every time a community nurse prevents an unnecessary 911 call. We don't, if they need 911, we're not trying to prevent the necessary, but an unnecessarily one, they save the community about $1,500. And this is an average because some communities say, oh, but we have volunteer ambulance, or we contract, or we have it's all volunteer at first. But I've asked a lot of the fire chiefs and town managers, like, what is a rollout cost? So you may not be paying staff, but you're still paying trucks and maintenance and gas. And so this is on average, and this comes from fire chiefs and town managers for some of the communities served by a community nurse. So if you think about that, and I'm not good at math, but how many 911 calls, and I said the number earlier, so 213 prevented urgent and ED visits. So what's 213 times $1,500? I have no idea. I'm not good at math. But we know this is probably budget neutral and can save municipalities money. We know it saves the healthcare system money, but we're not really talking about that. We're really talking about communities at this point. Every time a community nurse prevents an ambulance transport to the hospital. So again, if they've got to go to the hospital, that's great. But we hear, and I see Mark Boutwell on the call, we talk about it all the time. These older adults that live alone, they're scared. They call the ambulance. They end up in the emergency room. They don't need to be there. And then they're transferred home in the middle of the night. So it's a burden. And it also costs the client about $500 in out-of-pocket expenses. So, the numbers make sense to keep people, older adults, safe at home. Okay, now I hope this works. If it doesn't, I have a backup plan. Okay, so here is our website. And this is the way you can find if a nurse is available in your area. So you hover over contact a nurse. Currently, we support nurses only in New Hampshire and Vermont. We are open to supporting nurses throughout New England. But so I'll click on the Vermont button and I'll introduce you to some of the community nurses. So in Chelsea, Vermont, again, she is an employee of First Branch Ambulance. We have Jody Hoyt. In Heartland, we have Nancy North and Rebecca Maxim. In Hartford, we have Katie Williams. In Norwich, and I'm waiting for an updated picture of Mary, but Mary Stevens supports Norwich, Vermont. Kurt Wofield is in Putney. Rita Rice serves Reading and West Windsor. Clay Odell serves Thetford, Vermont. Sheila Keating serves Stratford, Vermont. Jody, who you saw from above, is also the health officer in Tunbridge and the community nurse in Tunbridge, Vermont. Kathy Schuster serves Westminster, North Westminster, and Westminster West. Regina Downer serves Weston, well, and she's getting a little help from Kathy Schuster as well. But they serve Weston, Londonderry, South Londonderry, Peru, Landgrove, and Andover, Vermont. And then we have Molly Madison, who serves Windsor, Vermont. So now I'm going to see if I can get back to my slides. It's amazing when that works. And just also to know, I mentioned we're a small nonprofit. I am the only employee and I'm part-time. And I am challenged with website and slides, but I have learned that if you Google things, it'll tell you how to do it. Okay, so that leaves us time for questions and conversations. And many folks that know me, that I talk to a lot, know that I live part-time on my boat, Water Lily. So I thought I would add a little picture of Water Lily there for you all.
Awesome.
So I will stop share and please, I open for discussion, questions, ideas, brainstorming, anything's on the table.
That was excellent. Thank you so much. Such some great information and amazing work. Anyone have any questions? Yeah, go ahead.
I'm curious whether are there other organizations similarly organized to yours in Vermont, in any part of Vermont? I know there's other organizations providing home nursing services, but organized in that fashion that you are, and otherwise, was there a model that you followed from another state? I understand the history that you gave, and that was great, but just trying to learn a little bit more. Thank you.
Yeah, great question. And we have researched it a lot over the last 10 years. There is not another organization like we are that we know of. And we keep looking. There's an organization actually out of Johns Hopkins School of Nursing in the Baltimore area that is doing neighborhood nursing, but they have not expanded it out. And they support very specific, that one very specific model. We know there are other community nurse programs throughout the country, but we don't know of any kind of convening organization that is supporting them. And we continue to look around, but we don't know of any.
Jane, good to see you.
Yeah, you too, Dan. Hi. Hi, everyone. My name's Jane Catton. I'm the CEO at AgeWell. And Kristen, thanks for your presentation. I too am a registered nurse and have a long career in healthcare and nursing. My question for you is, in your model, how are the nurses maintaining, or how is their scope of practice being overseen, and where are those accountabilities in the model for their clinical practice?
Yeah, it's a great question, Jane. Thank you. So, this model is, it's not like home health visiting nurses. So these nurses do not, they are not under a physician, meaning they can't do anything that requires a physician's order. So they can assess and educate, and in nursing language, they cannot treat. So they can't do wound care, they can't do an IV, they can't. And I talk with the Vermont, with the Board of Nursing in Vermont often to make sure these nurses are operating within their scope. They all carry their own professional liability service. In the state of Vermont and the state of New Hampshire, they don't, because they're registered nurses or higher, not operating under physician's orders. They don't need direct supervision. We do have the nursing collaborative. So if something comes up, a question comes up, they bring it there. Like, can I do X, Y, and Z? And I have to say, during flu season, every year it comes up. Can I give a flu vaccine? The answer is absolutely no. It requires a physician's order. Many people don't know that giving a flu vaccine is not just sticking the needle in the arm. It's got to be stored properly. You need to do an assessment to make sure there's no allergy. Like, it is really comprehensive. So they can't do anything that requires a physician's order. And again, because of scope of practice in Vermont, this cannot be an LPN or an LNA because they have supervision rules. And Jane, happy to talk more offline. So very different than home health nurses, very different from SASH nurses, who have some physic. I don't know SASH as that well. It's a wonderful program. I want it to grow in Vermont. I love it. So we don't want to overlap with those wonderful programs, but right now there are still gaps where registered nurses are needed in rural areas.
Interesting. Okay, thank you.
Hey, Kaylee.
Hello, I'm Kylie Kuiper. I'm the State Long-Term Care Ombudsman, and thank you for your presentation. I was curious, how do you define a community? You're talking about having one person in each community, and we have some super small towns, so I was curious how you define community. And I was also wondering if you could speak to if you have any experience. Do you find your model is useful in situations of self-neglect? Um, are 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 the community nurses able to get through to people with their education, or is that, maybe something that you can't speak to yet in your model?
Yeah. So your first question, on how we define communities, we don't define it. We let the communities define it. So, a good example, there's a small town where there is a town nurse, and she's an employee of the town. There is also a church in town that has their own parish nurse. So that parish nurse only serves church members, where the town nurse will serve the entire town. So it's really however the community defines it. A lot of organizations say, or a lot of communities or folks say, can you share a nurse between towns? And in theory, the answer is yes. But what I have learned in rural New England is just because towns are close together, they have very different values and cultures. So it depends. If the communities are really aligned, it may work for them to share a nurse. But usually the community itself, is very different, and they like to be different, and in individuals. So it's really however they define it, we will support them. Regarding self-neglect, so again, our learning collaborative, this comes up a lot. a lot of, and we talk a lot of like, what is really the definition? We actually had a psychiatrist come and talk about hoarding the other day of like, what is really self-neglect? What is really hoarding? So we talk about it a lot. And I will say, a lot of these times, these nurses build trust over time. So they are able to address some of those issues over time. They're obviously mandated reporters. So if there's an issue, they will report, but they also try really hard to build trust over time to understand and mitigate some of what's going on. So but again, we talk a lot about what are the real definitions of self-neglect, and we bring in people to help, that they can ask questions to in our nurse collaborative meetings. Again, really good questions. Thank you.
All good conversation. Thank you. Mark, good to see you today. Thanks for being here.
Thanks, Dan. Glad to chime in, and thanks, Kristen. So I'm the Executive Director of Senior Solutions, which is the area agency on aging in southeastern Vermont, which is, as you saw from the list of community nurses, sort of a hotbed of community nurse activity. And I've done a lot of work with Kristen and really appreciate our relationship. And I just want to speak a little bit to the self-neglect piece, and but also in terms of the relationships. And what I've done and what Kristen and I have really done together is talk about sort of the continuum of services and the value of community nurses and the value of other services such as SASH and such as the area agencies on aging. And as you all know, the area agencies on aging are mandated to support folks with self-neglecting behaviors. So I have worked very closely with several of the community nurses you saw listed to talk about how can we partner, how can we work together so that they're not out there on their own feeling sort of isolated and questioning, what do I do next? And so I want to say that Kristen has been a terrific partner in this, and we've really have worked to talk to the community nurses and say, yes, we value that you have this relationship with your client, and please know that you don't have to do this by yourself, that there are all these other services, and we can work together to support this person.
Yeah, thank you, Mark. Yep. As I mentioned, a community, they are not the solution. They are part of the continuum of care and part of the community services for these folks.
Yeah, that's a great partnership. Thinking about how, got these two relationships providing care to this individual. So yeah, that works out really well, I'm sure. Yeah, go ahead.
Are there any legislative roadblocks or things that you have considered asking of your legislators to help facilitate at-home care?
No, that's again a great question. I think a lot of what I think about, and when usually when legislators start talking about this, they start the conversation with the Department of Health and Human Services, with the healthcare folks. And I guess I would love to see how do we get this more into some of the and I'm probably not going to say the right words, but the regional planning committees and the town plans, like how do we get services for older adults, and not just community nursing services, but how do we get more services for older adults mentioned in those town plans? And again, I'm not sure I'm using the right language, but I guess that would be my initial thought.
Yeah, Brett, go ahead.
Kristen, thanks very much. you mentioned that the community nurses are not able to do anything that would require a physician's intervention or approval. And yet there was a large number, you also showed data that there was a large number of emergency room visits that were prevented and medication advice and so forth. So I'm kind of curious what that looks like in practice. So what is it that it seems like an interface there, that's kind of a thin line. So what does that look like in practice?
Yeah. So the community nurses, again, they can't follow physician's orders, but they can absolutely, and they do all the time, engage with the client's primary care provider, nurse practitioner, other folks. So again, they can't, like the doctor can't say, change that dressing 3 times a week and that kind of thing. But there's a lot of collaboration and engagement. So, a great example of understanding medications and medication reconciliation is when these older adults, they go and maybe have a hip surgery and they come out and their discharge paperwork is, 20 pages long and they're like, I don't even know how to interpret this. So the nurse can go over time and slowly explain and make sure they're kind of following that discharge plan. So it's not orders, it's the client's plan, but they can help them understand it. So yeah, it's kind of more, again, that assessment and education, but they are absolutely coordinating with primary care and any other provider, social service provider or physician that's involved. And again, they're not taking over like the case management. Like that is really not that, they're part of that web of all the care, that safety net, so to speak, for that client. But they are usually not the lead person that's involved in the home.
Yeah.
Thanks. It sounds like a necessary and valuable service. Thanks.
Good. I think that's probably Sarah with your hand up. Am I right?
Yes, hi, my name is Sarah Keating. I'm the project manager for Age Strong Vermont. I just want everybody to see the name Age Strong Vermont, so I put that in there. I have a question, but first I just wanted to speak to your comment about how do we get the kind of local level folks to think about aging when they're creating their town plans. And I'm currently working on a project to create multi-sector plans on aging, like a rural toolkit for smaller communities across Vermont. So I would love to connect about your ideas because I think that there would be a great space in those toolkits to include what you're talking about.
Yeah, happy to connect.
A question that I have, and this is maybe more for the group because I'm new and I don't have this knowledge, is just have there been conversations? Because, at this point, 1 in 3 Vermonters are age 60 and older. We had a very robust nursing workforce who went to school, say, in the 60s, 70s, 80s. And as those people retire, I'm just wondering if there have been conversations about how to make licensing, them maintaining their licenses, easier and more accessible so that they're able to engage in some of these examples you provided about people volunteering as a nurse and that type of thing. Thank you. And thank you, Dan, for today. This is amazing.
Yeah, if I can jump in, because that is a separate passion of mine. I kind of call it closing the back door to keep the nursing workforce. I can tell you almost every month in New England, a nurse tells me they want to come back in the workforce. They retired maybe pre-COVID or during COVID. And these are like highly skilled nurses who've worked for 25 years, but they've let their license go because they retired. Now they want to come back in the workforce, and the re-entry, and maybe this could be something we could work on. It's often $5,000 for re-entry, and they have to do some sort of education. And again, it's a little, I don't know exactly what it is, but it's cost prohibitive for them to come back, and they may only want to work in a nursing home per diem, maybe 2 days a week, but it is a valuable workforce initiative that we or group.
Yep.
We're leaving them behind, and we need to think about this. And unfortunately, I get it. The Board of Nursing, a lot of their funding is because of licensing and all this, but like if there could be a fund somehow to let these people, and again, there would need to be rules, but if they've worked over 25 years as a registered nurse and they've only retired 3 years, they haven't forgotten everything they know. So I'm very passionate about that, and would be would be happy to get involved in anything we can do to help that.
Yeah, that's something we could talk about here in this building. So I appreciate that. Yeah. A couple of weeks ago, someone talked about Vermont having the most experienced workforce, and I think that kind of draws into it right there. Go ahead, Jane.
Yeah, thanks, Dan. And Kristen, I just wanted to piggyback up on your comments around, requirements for practice and so on. And I think there is opportunity. I would love to see if the Office of Professional Regulation takes a look at how nurses can re-enter. The trick of it is how long they've been out and whether their clinical practice is up to standards. So often the costs are associated with getting back into the clinical realm so that they can demonstrate their competencies, and that's part of the rub. But I think there is a good opening here, especially with workforce, and knowing that mature workers and people who may have retired from nursing a little sooner than they expected are a great number, and they may only want part-time work. So I think it is a really good strategy to work with the regulators, how that reentry looks and how much it costs, and is key, but really focusing on the quality standards around practice and scope and competencies is quite important as well. So it's sort of a balance on both sides.
Yeah, Jane, I couldn't agree more. And you have to think, as a nurse leader, manager, somebody hiring, you have to look at that skill set, because these are not folks that are probably going to work 4 10-hour shifts in the ICU at the hospital. But, so again, there's got to be a combination there of, employers need to be responsible for the safety of hiring these reentry nurses. And how can we support some of the work, like as a community nurse, or, an OASIS reviewer in the nursing home. Like there are a lot of it, but I agree, it needs guardrails, because it is important to keep Vermonters safe and make sure nurses are qualified. I couldn't agree more. Yeah, the state of New Hampshire is kind of trying to say, we won't go to the state of New Hampshire today.
This has been super helpful, and what a great overview you've given us, and it's good stuff to think about as we look at our workforce, which was a topic of our committee this morning, actually, around more in the realm of nursing homes. But yeah, so all right. Any other questions or comments or anything? Fantastic. We're on the floor here shortly, so we'll be back next week. Thank you so much.
Thank you so much, Dan.
Great job. Thank you. Have a great day. Bye.